Hello, everyone. It's Debbie Bang, and with the E-QIP organizer, thank you for attending our experience-based co-design today. And I'm just going to start the slides, and then I'm going to hand it over to Paula. And we have everyone on mute. There is a place to speak to us in the chatting section. Jenna's just doing something here. Where's that? Okay, so there is a chat line there if you do need to mention anything to us, and we will try to respond. Okay, so the Excellence for Quality Improvement Project has been in place since 2016. We're on our second cohort, and it's a partnership between Addiction and Mental Health Ontario, Canadian Mental Health Association, and Health Quality Ontario, and its purpose really is to increase the capacity and support the community mental health and addiction sector to use quality and evidence to make decisions about the programming that they're providing. So it is our commitment to doing quality work, which we're already doing, and having a standardized way of demonstrating that to all of our colleagues. The objectives for today are to provide you with an overview of our experience-based co-design, and it really is a methodology for engaging clients and families in improvement and looking at it from a client perspective or through the eyes of a client as well. And these are Paula's, so I'm going to hand them over.
I thought there was more.
Nope, just the one.
Hi, everyone. It's Paula Blackstein-Hirsch. So today's webinar, as Debbie said, is on experience-based co-design. And the first few slides are just to put this methodology for quality improvement in context. Many organizations, likely all of you on the line, know that client engagement and their family engagement, partnering with them in service delivery is important. And I know that the mental health sector actually has been doing that for a long time in terms of having clients on various committees, including boards. This methodology goes slightly further in terms of engaging them in our quality improvement work. And there are a whole variety of levers from a policy perspective that point us in the same direction. One is the Putting Patients First legislation, which was just tabled this year by the Minister of Health and Long-Term Care in Ontario. On September 1st of 2015, there was an amendment to the Excellent Care for All Act, and for those organizations that are currently required to submit quality improvement plans to Health Quality Ontario and post them publicly, there was an amendment that actually required those organizations to engage clients in informing what goes into that plan and then demonstrating how, in fact, they had done that. And I do understand that in the most recent budget, there's been a message out to the mental health and addiction sector that quality improvement plans will be required in the future. And so anything that relates to that from prior legislation, I'm assuming, will also apply. And then there, depending on who your organization might be accredited with, there are more and more standards that actually reflect the suggestion that organizations engage clients and their families in meaningful ways in planning and delivering service. This is a framework that comes from a Health Affairs article in 2013. And for those of you who are familiar with the continuum of engagement that comes from community engagement work that's depicted across the top, that goes from consultation through to true partnership. And then the vertical, so that one is fairly well known by people. And it is true that many of us have consulted with clients over time to ask for their opinions, whether it's in terms of direct service or in terms of planning or improving service. This methodology actually takes us to the far right side in truly partnering in the planning and improvement of service delivery with clients. What I like about the vertical axis here that goes from direct care to policy making is that it allows us to think about different ways of engaging clients in a bit of a matrix. So as an example, something that might fit into a direct care row might be, and if you want to move right to the far continuum, it's that engagement of clients in truly developing or establishing their service goals. And I know that in the E-QIP initiative, there are a number of project teams that are working on that. Experience-based co-design and putting clients on committees or panels is included really in that middle row. And I include experience-based co-design in that middle row because it really is up to leadership of an organization in terms of thinking about how do we approach improvement within our organization, and is a methodology like experience-based co-design going to be included within our organizational approach. So this matrix might be helpful to you in the future in thinking about the various ways in which you engage clients within your organization. From a quality improvement perspective, many of us, myself included, who have backgrounds in healthcare delivery, did quality improvement many years ago without really consulting clients in any way in terms of capture or in design of our interventions, because we worked in the system and we figured that we knew what the issues were. But we're learning more and more that unless we actually tap into that rich resource of clients, that we can't make assumptions about what their needs are and about what might work for them. And so for truly to achieve our outcomes, we need not only to listen to them, which will come through in the capture phase of experience-based co-design, but truly not only listening, but also including them in co-design of what we call change ideas within the quality improvement context. So this is, these are the 4 phases of experience-based co-design, starting with capture. So it's about capturing through listening, and I'm going to share with you several tools. Capturing the experience of clients, then putting it, synthesizing it in a way that will help us to understand the experience, then co-designing change ideas to improve the experience, and then finally, of course, as we always do in quality improvement, measuring the improvement. And I'm going to share with you how the data that we collect through capture can actually be used then for 2 purposes. One is to understand the experience, and the second is actually to act as a baseline and then a follow-up measure for our quality improvement work. So I know this is a busy slide. I'm going to orient you to it and share with you the key messages in here. And this slide is intended to message how doing quality improvement work using experience-based co-design is different than solely using the tools that we train teams on to work with staff. So the project phases for quality improvement projects are depicted in the red bar in the middle, going from project setup through identifying root cause through diagnostic tools to coming up with change ideas, and then using small rapid cycle change, which is depicted through the plan, do, study, act, or PDSA cycles, and measuring as we go. What's below that line is many of the tools that we usually use in each of those phases for quality improvement. And what I put in red there is the ways in which traditionally in working with staff, some teams have included clients. So for example, possibly if they're doing a process map, sometimes people will bring a couple of clients into the room and ask them their perspective on what the process looks like for them, and primarily touching on those steps that they feel are value add or not value add from their perspective. Secondly, although we always do rapid cycle change, PDSAs, in the real work environment with clients, I would suggest we don't even necessarily go the full distance that we could in that context. There's a difference between, for example, a team what often happens is a team does a PDSA cycle, so they try something, and then they'll go back to staff and say to staff, was that, more or less difficult than before? Did it take more or less time? Did you find that anything was missing, etc.? Rarely do they necessarily go to clients and find out what that experience was for clients if, in fact, they're trialing or testing something that is intended for client use. And so even there, even though traditionally we engage with clients in that phase because we're testing, I don't think we go the full distance. When we use experience-based co-design, we are actually partnering with clients in every single step of that red bar, moving from capture, which is really our initial data collection, to appreciate root cause from a client perspective, and then pulling it together in a way that we can understand where the key opportunities are for improvement, and then partnering to co-design the change ideas, and then involving them in places that it makes sense in the actual testing of the change ideas. So for any of you who have been involved in improvement work with staff, you might recognize this. This actually comes from a community-based agency, and it's their process map, and this is often what it looks like. I would just draw your attention to the green Post-its at the top of that butcher paper, which are the high-level steps which would have been on the butcher paper before the team actually started mapping one level down. And so it's through that kind of process mapping and analysis that we determine from a staff perspective where the key opportunities are for improvement, and there are various ways of approaching that. Distinguish that from this, which is what we develop through the capture and understand phases. So this is the way that we synthesize the information, and that blue bar across the top, intake, assessment, etc., are the same steps that were included on the butcher paper for staff. The difference is the information that we collect from clients is, you'll see at the bottom, their positive and negative emotions as they go through those steps. And secondly, what I call triggers, which are the reasons underlying those emotions. So where did the experience, that's sort of a heads up of where we're heading through the capture and understand phase, but I'm going to back up for a few seconds or a few minutes now and just provide you with some background on where did experience-based design come from and how was it developed. So the methodology actually comes from the UK, an organization that existed until 2013 called the NHS Institute for Innovation and Improvement. That's the National Health System in the UK. Developed it in concert with a couple of researchers, and what happened was the then lead of the National Health System in the UK made a bold statement that said around 2004, 2005, our health system will be patient-led. And really, as sometimes happens with politicians, they make broad statements but don't necessarily have the operational details of how to make it work. And so he went to the NHS Institute and said, basically, make it so. So they hired a couple of researchers as well as some key people within their own organization. And what they did was they went out to the private sector, to organizations that were performing really well, and observed them to try to identify what some of their practices were that they thought were leading to their success. And they came out with three things. One of them was that these organizations did what they called discovery interviews, which is really qualitative work. Secondly, they did observation, which is core to our improvement work. And thirdly, they did co-design. And you may reflect and think about the number of times we hear about the private sector co-designing product with customers. And so researchers took those three concepts and said, we can take those and we can translate that to healthcare and come up with a methodology for improving outcomes in healthcare delivery. And so that's where this methodology was born. It's not rocket science. You will see as we go through this webinar that there really likely isn't anything that you haven't seen before. It's just packaged together in a structured approach. And so often if one asks an organization or a team of people to design improvement in a way that would meaningfully engage clients and really truly understand their perspective, you sometimes sort of get blank stares. And so this methodology really is just a structured approach with some methods and tools that help the team through that process. So I'm going to start with the capture phase of experience-based co-design. And at this point, I just want to highlight a few points related to recruitment. It should be of clients there, recruitment of clients and family. And I just wanted to say that the number of people that we include in capture is different than the number in co-design. So in capture, we want to include a relatively broad number of people, whereas in the co-design phase, we generally include a smaller number. And I'll distinguish between those two as well. And I also want to distinguish at this point between the people who you would recruit to be involved in this kind of quality improvement work as compared with the type of individual who you might recruit to be on your board or on an advisory committee for your organization. So oftentimes the criteria for adding someone to a committee or a board is that those individuals have had experience with your organization, and secondly, that they can think at a systems level, that they're representing clients broadly, they're not representing themselves and their own story. Distinguish that from the people who we want to recruit for capture in experience-based co-design, where we actually, yes, want people who have had experience with the organization, but we're actually specifically looking for people who have been involved with whatever it is that you're focused on redesigning. So for example, if you're redesigning your whole intake process, it has to be somebody who's been through that intake process. If you're focused on redesigning something at one site in your organization or within one program in your organization, then it has to be someone who's been through that site or through that program. And that's why you can't necessarily take someone who's sitting at a committee level in your organization, helping you in that way to participate in a particular project. You might be able to, but you may not be able to. So some other messages around recruitment is, one is, how do you identify clients to participate in this? So one way is that if your staff understand the methodology and understand what you're trying to do, they can help to identify people who they think would be good candidates to be involved and who might be interested in helping. Often the people who lodge complaints or disgruntled for whatever reason can often, as you know, become some of your best advocates. And so identifying some of those people, you don't want to make it all from that sort of pool, because you want to balance in the people who are involved. And generally speaking, in-person recruitment is more effective than more passive approaches like brochures, posters, or letters. But that is another method, and sometimes including a variety of methods can be helpful. I know that in some mental health programs, peer support is used, and this could be either clients who are involved in your programs or peer support. Individuals who have lived experience can be very helpful sometimes in recruiting other individuals to be a part of this kind of experience. I've already made the point about people having experience in the process you're redesigning. And then lastly, wanting to ensure that the individuals who you involve in capture are representative of your client population. So I talked about balancing, positive or negative, and any client who you involve is highly likely to provide you with both positive and negative feedback. but you certainly want to balance that to some extent in terms of those individuals who you know might land on one side of that line or the other. But thinking here about cultural background, about age, about whatever other variables you believe are important and that you believe could actually influence client perspective, it would be important to think about that stratification and think about the individuals who you might like to include. Just a word of caution here, not to identify too many, because the more strata you identify as being important, the larger your sample size will need to be, because you want to include several individuals within each. So that is an important thing to think about at the outset, though. Before I get into the methods, I just wanted to pause for a moment and highlight the fact that I know that many of you are currently capturing client perspective through the OPOC instrument. And I just wanted to reinforce a message that that kind of survey information collected in a standardized way in a longitudinal fashion over time is important and often very helpful. And it's not an either or, it's a both and. So I'm not suggesting that experience-based co-design substitute for that. That said, there may or may not be some questions within the OPOC survey that would help you specifically within the context of a particular quality improvement project. If there are, that can be a good starting place. And then actually doing experience-based co-design to dig deeper can be a helpful complement to the information that you're already getting through your OPOC surveying. So it's a complement. If you don't have information or a metric that you think links directly to your project, however, this kind of methodology can provide you with both your baseline and some of your follow-up measurement, in addition to providing you with a lens on what the needs are, or what the root causes are from a client perspective. So I'm going to move right along here. The capture tools that we include are interviewing, and an interview is, what I'd like to emphasize there is open-ended questions. So basically the key is opening up with information on what the focus is of the improvement initiative. You can anchor it if you'd like with the kind of steps that you believe the client might have gone through, but then really opening it up and asking them to describe their experience through those various steps while you listen for information on how they felt at the various steps and what was triggering those emotions at the various steps. Shadowing and observation are really one and the same in terms of it being going out and watching a client go through the process. Shadowing is following an individual client, whereas observation is in a group setting. Filming and photography can be very helpful. It's one thing for a staff person to share with a group of others what clients said. It's quite another to hear it right from clients. And so iPhones are a great way of doing that. You obviously need, as soon as you bring in photography or film, you need consent. But it can be very powerful. And as an aside, it can also be a very powerful change management tool, because there's nothing like hearing what the experience is from the clients who are using your service to spur people on to believing that change is required. Photography can be done as well. That's still photography as compared with filming an interview. Some organizations have used those throwaway cameras where individuals are asked to take photos of things that they find positive through their experience and other things that they find challenging. Storyboards can be a storyboard that someone draws, a collage that's put together, or photos that depict the person's experience, and then sitting down with that individual and having a conversation about what the meaning of that storyboard is that they put together, and then delving deeper to understand their experience. A diary I will come back to after I share with you what an emotion questionnaire looks like. These tools that I've just described are depth tools. So they're the kind of tool which will provide you with a richness of information, a richness of the experience that clients have had, whereas the ones on the right that give you breadth, you can do on a larger number of people, and it's because they don't take as long, and you don't get the depth of information, but you get numbers. Because we don't want to be reacting to the information from a few. We want to make sure that that is a broad experience that we're taking the time to redesign for. So an emotion questionnaire is not likely something you've seen before, and I'll share with you what that looks like in a moment. Focus groups are likely something that a number of you have used. And then I put observation over here as well because it's observing a larger number of clients at one time. I just want to emphasize a couple of things. One is that I always encourage doing both depth and breadth. That said, I have actually most recently actually combined a couple of tools on the right side, an emotion questionnaire and a focus group, and found it to be a quite effective way of getting both individual and group information from the client perspective. In terms of numbers, it's generally, the rule of thumb is just like any other qualitative work, where from a depth perspective, the number of clients you might include might be 6 to 10, but the notion is, or the concept is, when you get saturation, meaning you're hearing the same thing over and over again. That said, if you don't have the resource, and many organizations don't, to do that number, for the depth tools, I always say having even a couple of interviews is better than having zero, because you get some understanding that you didn't have before. The numbers involved on the breadth side can be anywhere from 25, 30 up to 40, but that gives you the numbers that you can feel confident that you've tapped into the experience of a good number of people, and that you've validated what you're hearing through depth. And you've also got the numbers that if someone questions you and says, oh, well, that doesn't really describe our population, if you've done the stratification well and you've got some numbers, you can feel confident that for the purposes of quality improvement, you've got a good sample of individuals. The information that we seek, regardless of the tool that we're using, is being able to visualize the journey that that individual is going through. So what are the steps in that person's journey through your health, your service delivery? Listening for emotive words, both positive and negative, and then understanding the triggers or the reasons underlying those emotions. Those are the only 3 pieces of information that we need in order to get an understanding of the client perspective using this methodology. This is an example of, and I have CMHA Nipissing's permission to share this with you. So Laura, one of our coaches, used experience-based co-design in her E-QIP project last year for their own organization. And what an emotion questionnaire is, it differs quite significantly from a usual text-based survey, is putting those steps that you see in the green across the top. In this case, we actually included space for steps between, because sometimes we don't actually appreciate some of the steps that clients go through. So this was providing them with the opportunity to not only identify steps that we might not have thought about, but also often, as we know, it's the time between steps that is the most emotional or challenging for clients. And so they specifically put in some of the weights and wanted to hear how people felt at those points in time. There's a standardized list of emotions that people are intended to circle, what word or words reflect how they felt at that step, and that list of words is created by the organization. I'll share with you, I think I've included in here a list that you can start from. But these are really up to you to think about, and I would balance the number of positive and negative emotions so you don't bias the response. And the intent of the line underneath is if one of those words does not describe how they felt, they have the ability to put in their own word, and then the box below it is to fill in the trigger, or what was the reason for them feeling that way at that point. This is a similar format, but you can see that this organization used emoticons or emojis, whatever you want to call them, rather than words, or they used them in combination with words. And this was done, in this case, for a population of individuals who had slight cognitive impairment, but it could also be used for children, wanting to ensure that you're only using this sort of format, though, when it is applicable. I did hear feedback from someone once about using it and getting negative feedback, and when I asked who and how they were using it, it was with a group of adults who didn't need that in order to understand, and so it felt sort of pedantic. So I'm coming towards the end of the capture phase, and what I want to emphasize is, and this quote at the top comes from Paul Batalden, who is a guru in the quality improvement world. But I'm sure many of you have heard this quote, that every system is perfectly designed to get exactly the results that it gets. And I was reflecting on this one day because despite doing workshops on experience-based co-design, I would often then be in the position of coaching teams and see that despite the coaching or the messaging around open-ended and really not going in with closed-ended questions, people often didn't have the confidence to do that, and they ended up actually presenting to clients closed-ended questions. And so I was thinking about that quote and thinking that the methods that we use for capturing information as well are designed to get different types of information. So if we want yes-no answers, ask a yes-no question. If you want a Likert, a range on a Likert scale, then ask a close-ended question and provide a Likert scale. But if you really want to get the depth of information that doesn't presume that we know what's important to someone, then, and I respect the fact that surveys are actually designed with clients, but in individual situations, not presuming what's important to them, then we need to use open-ended methods and not go in with specific questions. That said, if there are some specific questions that are important that you want the answers to, I would put them at the end of an interview or ask them after people finish completing an emotion questionnaire, so that you don't, again, the minute we put something in front of someone, we sort of narrow the field of where they're going to go, because they'll naturally go to what's put in front of them. And this is on the same theme. This comes from the King's Fund and Glenn Robert, who was one of the original researchers who developed this methodology. And he just makes the point that asking too many questions puts the interviewer in control and reduces the opportunity to hear what's really important to the person in front of you. So it's just a plea from me to really stay true to the intent of the methodology by keeping it open-ended. So I'm going to move now to the understand phase of experience-based co-design. And really, I've shared with you what this looks like. It really is about pinning emotions to various steps in someone's journey, and then identifying the triggers or the themes that underlie their emotions at each of those steps. And this slide is just to say this comes from the NHS Institute, but this was, it's called an emotional map. So this is their synthesis, where they actually identified the powder blue steps at the top. This was a clinic situation for them. And what they found out was that when they actually went to patients to talk to them about this process, the steps in purple actually came out from their patients. And so, as providers of service delivery, we always start at intake or at registration. And that's not where clients start. Clients start back in the parking lot or when they're on the phone trying to get through on the phone line to make an appointment for your organization. And so leaving that space to allow people to start where the process starts for them and to share with you how they felt at those various times, and then capturing the triggers is really important. This is an emotional map, just to give you a picture of another one. This is some work that I just did with one of the LINs in Ontario, and it was looking at the process between home care and primary care. And in this case, what ended up, the result of this was that people were actually generally quite positive overall. However, and we did this in 5 different subregions, and they looked a little bit different across different subregions. But generally speaking, what came out when we put all 5 together was that there were more negative comments at the first step and the third step. And so what this does for you when you put this information in an emotional map like this is, I'm going to flip back just one, is where the emotions cluster, particularly the negative ones. You can look at both positive and negative clusters of emotions. The positive ones are where you're doing well, and you want to make sure you retain those things. Where you get clustering of negative emotions, that tells you where in the process to focus. So that tells you where. Understanding what the root causes are from a client perspective come from the triggers on top of the emotion. So in this case, many of the opportunities for improvement are identified in the referral to home care, and then there were a ton of issues for clients while they were actually receiving visits in their homes. And so that told us where, but we needed information from the triggers in order to understand what their issues were. And incidentally, I mentioned just before that I had combined 2 breadth tools. In this project, what I used was a combination of emotion questionnaires so that I got individual input from individuals at the outset, and then we took their emotions and put it up at the front of the room, and then had a focus group to get dialogue on the triggers for their emotions. And so that was a way of mitigating the risk in a focus group of getting groupthink, but also getting individual input. And it also allowed us then to create some really nice measures using the emotions, which I'll show you later. This was done by someone in a primary health care environment. What this individual did was she combined something I'm going to share with you later in measurement, but it is in a way an emotional map, and it's a way of, you can do it on butcher paper with Post-it notes on a wall, or you can do it on your computer and synthesize all of the information in this way. So she has the steps across the top. She has positive in green and negative in red. She put her emotions at the top and her triggers at the bottom. And what she did was every time an emotion or a trigger was mentioned a second time, she increased the font size by 1. I thought this was rather brilliant, and it really was combining 2 things that I had shared with them, but putting it together into one. And you can step back from this, and it's very clear that the key opportunity for improvement was patients being frustrated by being put on hold for long periods of time when they called in to the clinic. So moving on to improve, I'm just going to spend a minute on this phase, because this one is the one that probably differs the least from our usual improvement strategies that we use with staff, but this is where co-design comes in. So it is about bringing people together. And this slide just highlights some of the nuances that are a little bit different when we work in partnership with clients. So one of them is planning in advance, and certainly we'd want to do that with staff, but we want to ensure definitely that when we're involving clients and families, that that you plan well in advance to ensure that they can come. We never really worry when we invite staff to an event, how they're going to get there. And, you know, we generally, unless it's out of town, don't cover their travel expenses. But certainly when we're inviting clients and family members, we need to think about how they're going to get there. It might be that Wheel-Trans is required. It might be that we need to pay for taxi expenses, whatever the case might be. Really important to use simple English, not to use acronyms, which we often try to do, and even when we try to do it, we trip up often. So actually asking people to call you out on it, and really you can make it even into a game. Remembering that staff are often as nervous as clients and family members, because as staff, we're often in control of the situation. But in this case, we're really trying to it's really trying to equal the client staff goals and really make clients feel as comfortable as staff and vice versa. So something like name tags, for example, not having staff wear their own organization name tags if you have them, but just having the same name tags for everyone. If you've got a number of clients and you've got various tables, so clients scattered across various tables with staff, having someone identified to ensure that the clients are brought into the conversation, that staff aren't taking control. And then in quality improvement, we never leave without saying, what are we going to do next Tuesday or next Monday? But certainly staff don't want to see their efforts put on a shelf and not acted on, but given that these people are giving us their time and really opening their hearts to us, wanting to ensure that they either are involved in the follow-up action, but definitely they see what the action steps are coming out of this particular phase. And this is where you bring people to the table, and you can use a variety of methods, which I won't go into now, but are many of the tools we use with quality improvement teams to get people, kind of break the ice and get people generating creative solutions. One of the things that, one of the advantages of doing co-design with clients is that as healthcare providers, we bring our healthcare experience to the table. But what clients bring is not only their experience as clients of your organization, they also bring their backgrounds. And so there's a whole host of career experience and expertise that you can tap on by having these people at the table. And it will change the conversation at the table. It will change what you find from a root cause perspective, and it will also change ideas that come forward as a result of doing co-design, as compared with only including them in capture and not in the co-design phase. I just wanted to highlight for a second at this phase, this isn't formally part of experience-based co-design, but there are a whole host of literacy resources. And often when we're designing change ideas that clients we serve are intended to use for self-management, because we need to remember that we are with people about 5 or 10% or less of their time, and they're on their own needing to self-manage, and often some of the change ideas are intended for them to use on their own out in the community. When they don't have us in front of them, or even if they do, they might not understand what we're saying. So making sure that we pay attention and take the time to think about client literacy or health literacy and the extent to which people actually understand what's in the design of tools that we're creating. Really important, because if they don't, then all of our efforts and the time we spend with them are really for naught. So moving on to measure, because I want to make sure that we leave enough time for questions. So the gold standard in quality improvement, as many of you on the webinar will know, is using charts, which reflect data over time, so that we can actually put the change in context and see patterns in the data. We're looking at the variability and the variation in the data, and hopefully as a result of a quality improvement initiative, we would actually see change like you're seeing in this slide. That's how we measure from a quantitative perspective. If, as I mentioned before, if you have an OPOC question that relates to your project and you can put data like this on a chart, that's fantastic. But we can also use the information we get from experience-based co-design to complement this. So here's an example of a Wordle, and this kind of pulls back that primary care example that I was sharing with you earlier. And this is particularly easy to do if you've used an emotion questionnaire because of the standardized set of emotions that you're putting in front of people. It's a bit harder to come up with if you've done interviews because people might be expressing a similar emotion but not the same word. What a Wordle does is every time a word is repeated, it increases its size. So it's a way of taking what you hear as people's emotions in baseline, and then if you follow up subsequent to your change ideas towards the end of your implementation or beyond, and do the capture again, you will then hopefully see a change like you're seeing on this slide. And it's a really neat way of sharing a change in the client experience. I'm going to breeze through this because I do want to leave enough for questions. I wanted to put in an example, and this is a community-based example. I don't yet have a full example from an E-QIP project, even from the last 2 years yet, to include. But this was Acclaim Health, which is a community support service organization, where they were having a challenge with a day program for individuals who had dementia. They gave a journal to their loved ones at the end of the day when they came to pick up the individual, and it was a journal that would share what they did over the course of the day, what the participation was like, and any sort of comments in terms of what they ate, what activities they were involved in, any other sort of notes. And what had happened was because they had shifted the method for doing this journal, their satisfaction ratings had decreased from 98% to 78% over 2 years. Staff found the whole process very time-consuming, and the organization had multiple sites, and the process was actually being done inconsistently across their sites. So they felt like they wanted to do something about this, and so they used a quality improvement process to do that. What the staff did was they did a process map, and they identified a lot of wasted time. They identified their root causes, and what the staff concluded was that the method they were using was ripe for error, that it took a lot of time, but the only way that they could think of improving upon that was going back to a really older method, which took a huge amount of time because they actually wrote a narrative over the course of the day for each client. And so they really didn't know how best to resolve the issue, and their director was familiar with experience-based co-design and said, why don't we call in some of these caregivers and actually ask them? So that's what they did. They recruited, in this case it was pretty small, 4 caregivers, 1 from each of their sites. They had a varied length of stay in their day program, and they had their supervisors recruit them, and they had a letter drafted in the event that they didn't get enough people, and they used the same group in their follow-up. They intended to have a focus group with these people. It ended up being, they planned it for 90 minutes. It ended up being close to 3 hours because these people were so engaged. And they facilitated it on their own. And I just wanted to share with you what the journal looked like before. So you can see it had the times, it had all of their activities, and what I've highlighted there was words that I circled that they didn't really know what that meant. And it was all basically, we did this, we did that. And it was generic. It was not a personalized journal. What the caregivers suggested to them was a similar kind of journal, but to put in a participation and a food level, which there's a legend for at the bottom, which would actually then reflect the individual's level of participation and any notes about food, because actually what had happened was they would indicate what in the older journal what the snack was, and in some cases that was actually a health risk for individuals. So not only was it not personalized, it was actually not accurate to what the person had been doing, and it actually raised alarm bells for some people when they picked them up. So here are their results. And this is really simple. This is one tool getting caregiver input in a small focus group. So their satisfaction ratings bounced back up almost immediately. The time it took reduced significantly, and the number of errors reflected in those journals also reduced significantly, simply by asking people who are the end users for their input. And they were the ones who came up with that scale. So I'm going to pause there for questions. I think we probably have about 5 minutes, because I know that Mike is going to close out the webinar with a few slides, and I don't want to steal his time. So anyway, if we, oh no. Looks like some people had some power outages. I guess that's maybe because of the weather. Wondering whether anybody wants to ask questions. Is it, Jen, primarily through the chat?
Yes. Yeah. If you have any questions for Paula, just type them in the chat box that should be on your GoToWebinar window.
We'll just give you a minute or two. Hard to believe that, I don't know how many people are on the webinar. 50. Oh, yeah, 50 people. Hard to believe there wouldn't be one question. About anything about how this might jive with current methods that you're using, about specifics. Wondering if you could speak a bit more about different quality improvement methods that could be combined with this, say in addition to the use of the OPOC. So I was referencing the OPOC specifically in relation to measurement, because it is a method for quantitatively, I appreciate it's a Likert scale, but that is what we use from a quantitative perspective for client perspective. And so this is a way of taking information that you capture anyways, that you gather anyways in the capture phase, and using it as a measure that's a sort of a semi-qualitative, quasi-quantitative way of pulling it together to make it a measure. The other quality improvement methods, this overlays, as I showed in that first slide where I had the red arrow of the phases of a project, whatever quality improvement methods you're using. So whether it's the model for improvement, whether you use Lean in your organization and all of the methods and tools that are involved in Lean, this is intended to be used in parallel with those quality improvement tools. Lean method, the model for improvement, those are tools that we generally engage staff in. The tools I've just described are in parallel the tools that we use to engage clients. Is there another one? Do you have any? Wondering the time frame from step 1 to step 4. That's a good question. So it varies depending on the methods that you're using. Recruitment will take a little bit more time than obviously bringing staff in to a team, or even broadening beyond the team. So, it could take you a few weeks to recruit the individuals for capture. And then what I didn't say is we often use a subset of those individuals who can think more at a system level for the co-design phase. The capture phase is what takes the time. Co-design takes no longer than what you're doing with staff, because you're bringing clients into the room to co-design with staff. So it depends on the tools. If you're doing serial sort of interviews, depending on the number of people that you've got doing them, that's going to take you a little more time. But if you do what I described, for example, with the LIN, the emotional map I shared with you, that actually just takes the amount of time that it took to run a focus group. So it was a 2 to 3 hour session. I think it was 3 hours actually. And then synthesizing the information probably took about a couple of hours. So hopefully that helps. So it's the recruitment that you need a bit of time for, and then depending on what methods you use. The interviews will take you a little bit longer. Other methods, not quite as much. Do you have any advice for using EBD with a network of organizations? I don't think a network of organizations are really any different. In fact, that LIN work that I described with you would really have been, clients of multiple organizations. I guess that's a whole other webinar and discussion, but for a network, presumably you've got a shared purpose, like you've got an initiative where you've got a shared purpose, and you'd be combining clients from your various organizations to understand the experience, and then depending on what the change ideas are, some organizations might be taking accountability for certain change ideas, other organizations for others, and so I don't really think it's any different. It's just a broader group of organizations versus one. What are some of the strategies for avoiding tokenizing client and caregiver involvement, i.e. ensuring their input is put to use in an impactful, meaningful way? I actually believe that experience-based co-design is a way of doing that, because it isn't just ticking off a box. And so if I go back to that first slide on, for example, the Excellent Care for All Act amendment, my fear when I saw that was some organizations sitting at a table with clients and saying, here's our quality improvement plan, what do you think? Tick, client engagement, right? As opposed to actually going through a method like this that provides you with a richness of understanding of what the client experience is, which then forms the root causes for the projects that go into your quality improvement plan. So I don't understand how you could go through a process like this and then think that it's been tokenism, because it is really getting a depth of understanding and really getting clients involved in a meaningful way. And I can tell you that through that LIN work that I just did, the people who were involved in that work thanked us for involving them. They so appreciated being involved. They so appreciated feeling heard, which happens over and over again. And we had a list for them to sign up to be involved in then the co-design session that we brought them back to and just held actually last week. And we held actually a World Cafe for the session that combined, in this case it was patients and providers. And as we went around from group to group, it was the patients in those groups who kept grounding the conversation, where providers said, oh, we can't do that. The patients actually said, well, if you want to make it patient-centered, we're going to have to figure out a way to do that. And it changes the conversation, and that is not tokenism. That is truly listening, understanding, and then listening. Are there any other questions,
Nope.
Jen?
I think that's it.
Okay, Mike, I think I have stolen a bit of your time, so I think we're gonna move through and not take any more of your time. So over to you.
Great, thank you very much, Paula, and a huge thank you for sharing your wisdom when it comes to experience-based design. It's a very specialized area, and I think a very meaningful one. So thank you for taking the time, and hopefully folks have found that very useful today. So we don't want the conversation to end here. I think, it's one important thing we'd like to encourage is for folks to take some time and check out our community of practice, the E-QIP community of practice, which is nested on the Health Quality Ontario Quorum site. And we'd love to hear from you around, one or two of your key learnings or takeaways from today, from this discussion, things that maybe sparked your interest or opportunities that you see to apply some of this learning to your work or to your agency. So we'd love to encourage you to join in the conversation on our community of practice. And to do that, it's pretty simple. You don't need any special permissions or anything from us. You can just visit the Quorum website here and search the E-QIP community of practice and join that group. And in addition to conversations like the one here relating to experience-based co-design, we also have a wealth of tools, templates, past webinars, newsletters, discussions, profiles of E-QIP quality improvement projects, and a lot of information that will probably help you further your quality improvement work and journey. If you have trouble too, please let us know with respect to the community of practice, and we can help you navigate through it. In addition to that, a couple of upcoming trainings and things that will likely be of relevance or interest to folks in the sector. One being a very important session, which is going to be hosted by Paula as well as Health Quality Ontario, looking at governance and leadership for quality improvement. Really a timely session given the ministry's recent announcement that included that our sector will be eventually enrolled to the Quality Improvement Plan program and expected to report or encouraged to report quality improvement plans. So there's an opportunity with this training to help board members and senior leaders understand their important role in quality improvement and what that looks like. So I would encourage you to take some time, visit the link here and get more information about that upcoming session. As well, Health Quality Ontario is offering a webinar on measures. That's coming up on May 10th, and you can register at the link here included in your package. And in addition to this, IDEA's Advanced Learning Program, which is a partnership between Health Quality Ontario and the University of Toronto, is offering 2 cohorts in the coming months. And these cohorts have some dedicated spots available for the mental health and addiction sector. And this is a pretty big opportunity to take a problem or challenge or opportunity that you're facing or your organization or community is facing, and take it to the Advanced Ideas Quality Improvement program, where you'll receive lots of learning and coaching support on how you can apply the quality improvement tools and methods to improve what it is you're experiencing. So there's some dedicated spots there and some subsidy funds available through E-QIP to support folks in attending that. So if you're interested, please reach out to us, let us know. We can give you a lot more information about that and what's available in terms of subsidies and support. Lastly, all of the webinars that we deliver as part of E-QIP are available to you recorded on our YouTube channel for those who are tech savvy, and all the links to those are included here. You can also join our email list and receive all of the exciting information about upcoming offerings and opportunities and resources so that you can be sure you don't miss anything important that's related to quality improvement or data. So we'd encourage you to check those out. I'll also offer it here. It's not all on the slides here, but I'll just do a plug for it. If this work on experience-based design has really sparked your interest and you want to pursue that further, we're currently E-QIP currently in the phase of supporting a number of projects through our quality improvement and data coaching to do quality improvement work. But we will be offering another cohort beginning late summer. So you'll see that call out for applications. So there's an opportunity there to, if you're interested, to apply for quality improvement and data coaching support from us to work with you to tackle a challenge or opportunity and maybe apply some of the experience-based design principles and tools to your scenario. So please feel free to reach out to us. This is the contact for our team. We're happy to talk with you anytime about all things quality, so please feel free to contact us if you so desire. Again, thank you very, very much for participating in this webinar. Hopefully you found it very, very useful, and thanks again to Paula for leading this. And we'd ask that you take a moment to complete this very brief survey to let us know how we did, if we can improve our webinars, and if there's future topics that you'd like to hear about. So thank you very much.